Alright you guys, my name is Matt. Today we're going back with another really awesome video. I really think you guys are going to like this because this is something I've always wanted to kind of do a video about. But it seems now I actually am going to do it. So this is going to be the top 10, maybe not the top 10, but this is going to be 10 misconceptions about mental illness in general. So obviously I could pick from a million different ones of these, but these are 10. Some of these are personal experience, the rest are just, these are ones I hear all the time. So you could probably just call them the most prevalent, at least some of them. So that's what we're going to talk about today. So the very first one is going to be the idea that mental illness is rare. Now, first of all, can we first appreciate the fact that this beautiful background, isn't that the coolest thing ever? I mean, look at it. It's beautiful. But, so this idea that mental illness is rare or otherwise just uncommon, we're going to see that this is not exactly true. So, the statistics here that I was able to find is 1 in 5 adults in America experience a mental illness, and nearly 1 in 25, about 10 million people in America, live with a serious mental illness. Now, of course, it doesn't necessarily define what a serious mental illness is, but from what I've read before in the past, different places, it would be things like schizophrenia, dementia, bipolar disorder, major depressive disorder, PTSD, things like that. Not to undermine other people with other disorders that might not be as severe, but those are generally ones I've heard considered to be serious mental illness. So use that as you will. So clearly, just by the statistics alone, this is not some rare, unsightly thing. This is far more prevalent than I think most people realize, which is why it is such a big deal. Alright, so on to topic number 2. This one has to do with bipolar disorder. Alright, so as you guys know in my last video, I did discuss this a little bit regarding bipolar disorder versus BPD, borderline personality disorder. We already clarified that BPD does not stand for bipolar disorder, even though it shares the same letters. This is for borderline personality disorder, which is an entirely different construct than bipolar disorder, mostly because bipolar disorder is classified as a mood disorder. A personality disorder is an entire classification of its own. There's actually 3 different classifications of personality disorder. 3 clusters, they call them A, B, and C. Basically, A would be kind of the odd, eccentric, unusual cluster. This would have things like schizoid personality disorder, schizotypal, things like that. Cluster B will be kind of the emotional kind of ones. So this would include borderline, narcissistic, and just one more, histrionic. And then cluster C would be the anxious and fearful cluster, and that would have things like obsessive compulsive personality disorder, which is not the same thing as OCD, obsessive compulsive disorder. They are very different. This would also include dependent personality disorder and other things like that. This is not a video on personality disorders, but that is how they're broken down. As you can see, they're entirely on their own from mood disorders or any other type of mental disorder like bipolar disorder. So these are not the same. Now, I don't actually have the criteria for bipolar on here, but to reuse this one from the DSM criteria for BPD, I said in the last video that there were a few similarities. The only two real ones that are shared between that and bipolar, number one would be the impulsivity. That's very common. That includes spending sprees, promiscuity issues, substance abuse, reckless driving, binge eating, etc. That's really one of the biggest two criteria. The other one would also be the general emotional dysregulation, the mood swings and things. Those are very common. Obviously, in bipolar, it's mania and depression. This is more of the extremes of the evaluation and devaluation, the love-hate cycle, basically. So they're different. They're done in different ways and for different reasons. But the general idea of emotional dysregulation and impulsivity are the only two real symptoms that line up pretty similarly between BPD and bipolar disorder. So they're not the same thing at all. Alright, on to the next category. This one's going to be about anxiety. So the idea here, of course, is that anxiety is a very common mental illness. But all too often you'll hear something on the lines of someone is being accused of using their anxiety or depression or panic attacks, anything of that nature, as an excuse or a crutch to get out of doing something or going somewhere that they don't want to. I've heard this a lot. This is really annoying, by the way. The idea that this is just some sort of crutch to get out of doing chores or going to work or keeping plans with a friend is very frustrating and very untrue. As someone who has actually had to cancel plans and rearrange plans due to my anxiety, this notion that I wanted to just get out of doing anything is very untrue. I would love to see my friends, even in groups of the friends. But sometimes it's a little bit too much for me, and I know that. And it's easier for me to just say, hey, can we catch up a different time? Maybe just me and you, or maybe at a place that I'm more familiar with. Being in a crowd of people I don't know, in an environment that I've never been in, is very bad for my anxiety. And luckily my friends know that by now, at least for the most part, and are pretty understanding of that. And so, yes, that's really good that we have that kind of communication now. So it's not just about trying to, I don't want to clean up my room, so I'm just going to say I'm really depressed and sit and binge Netflix all day long instead. It's not like that. It's a real medical condition, and it is very exhausting and debilitating at many times. And having the courage to say, this doesn't really work for me, that takes more guts than just sucking it up and putting yourself into a very uncomfortable or just, unpreferred situation just to try to make somebody happy. So that's how I look at that. Not an excuse to get out of doing something. Alright, so the next category is going to be for PTSD. Alright, so PTSD, post-traumatic stress disorder. We've all heard of this a million times, but unfortunately there's a very common conception about a very specific type of group of people. Wow. there's a misconception about a small percentage of people who have this. That, of course, being people in the military, people out fighting wars and battles, and seeing and enduring some horrific sights and things happening to them. As you can see, combat exposure is listed on the guy side, although I'm only assuming that's because there's less women serving in the military than men. But that's not to undermine the fact that women can't endure that as well under the same scenario. So, whatever. But regardless, combat experience, while it is very high on this list, as you can see, and I'm not sure where exactly these numbers are gotten from, or this, kind of percentage to rank these categories. Not sure where they got it, but it makes sense that combat exposure would be very high on the list because it is the most thought of reason or cause for PTSD. That does not mean it is the only, and it does not even mean it is the most common or severe. All situational, of course, but here you can obviously see that there are many other causes, mostly involving neglect and physical, emotional, mental abuse and trauma. So it goes far beyond the stretches of the battlefield, and that is important to keep in mind. This is not a military exclusive disorder. This can affect anyone that has undergone any sort of trauma or attack or sexual assault. It does not matter. It does not discriminate. So that is important to remember. Okay, so number 5. This is one I used to read up on a lot. This has to do with what in the world does borderline mean in borderline personality disorder. Okay, so borderline in borderline personality disorder, what the heck does that even mean? Where did that name come from? Well, first of all, it's important to notice that in certain parts of the world, a lot of Europe, for example, they use a different kind of diagnostic manual or handbook, whatever you want to call it. We have the DSM, which has been around since 1952, when the first edition came out, and it's been revised multiple times to the most current edition, which is the 5th edition, which came out in 2013. So there's been lots of revisions and things over the years, things added, things dropped. The way that these conditions were classified has been changed numerous times, especially since the DSM-3 onwards. So, again, we have the Diagnostic and Statistical Manual of Mental Illness, or mental disorders, rather. Other parts of the world use something called the ICD. I forget exactly what it stands for, and if I was smarter, I would have Googled it beforehand. It's like International Common Disorders. It's something like that. It's international something. But basically, it's just another form of a DSM-like manual. The only thing is with the ICD is that it actually is more than just mental illness or mental disorders. It's also physical disorders as well. So a lot more topical. Whereas the DSM, of course, is only of mental disorders. However, in the ICD, BPD is actually referred to as emotionally unstable personality disorder. You'll see it abbreviated EUPD often. It's the same criteria, more or less. They just decided to change the name in their manual to something that kind of describes what borderline does not adequately describe in terms of a realistic working definition and name that really fits the identity of what these symptoms are. Now, the reason borderline is what it was originally, and is still mostly referred to as, over EUPD. The borderline part came out of one of the early DSMs And it was really based around the idea of observing patients in asylums and mental institutions back in the day. And these people, they seem to fit, or rather not fit, neatly in a category of somewhere between neurosis and psychosis. So essentially, these people seem to be very anxious and worked up a lot of the time, and then other times they could present almost psychotic with these intense beliefs of fear of abandonment and these really high emotional dysregulation that led to a lot of really different behavioral and thinking patterns. So they didn't fit in between the idea of, say, someone with just an anxiety disorder, and they also didn't fit in with the fully psychotic group of people, such as the schizophrenics. So this term of being in the border of being neurotic and psychotic is where this borderline word came from. Like I said, some parts of the world will prefer to use the EUPD, the emotionally unstable personality disorder, but that is where the name comes from. It is not really about being partially normal or partially neurotypical and partially insane. It's the border of the other two categories is where the name came from. Okay, topic number 6 of misconceptions on mental illness. This one is very important. And this one revolves around self-harm. Now, this one is very controversial. It's not really controversial because of the belief itself that people believe associated with this. One of the many things people believe associated with this issue. But it's more controversial the fact that people believe that only a certain group of people who look a certain way and act a certain way, maybe listen to a certain type of rock and roll music, are the only people who participate in these self-injurious behaviors. And even more to the point, that this behavior is only done to get attention. Now, obviously this is very, very, very damaging to tell someone who does behave with self-harm behaviors. First of all, the very idea that the only people who can self-injure are the emos and the goths and the kids that dress like rock stars. That idea is just fueled by pop culture and stereotyping. The idea is anyone can self-harm. Anyone can do these behaviors. This is not an exclusive to teenagers or to the emos and goths and related subtypes of people that are stereotyped as being the predominant people who do this behavior. Any of the behaviors. It's not just one. It's not just cutting even. There's burning. There's a lot of other ways you can hurt yourself. I'm not going to name them. Of course, cutting is the most primary thought of one. But there's far from just that when it comes to this issue. So that's another misconception. Don't have it on here, but we'll include it. Cutting is not the only form of self-harm. Teenagers and emos and goths are not the only people who can do self-harm. Anyone can. And this idea that it is done for attention. Another thing I've heard is that it is done, basically if someone self-harms, it's basically a suicide attempt. Also, research has consistently shown that this is rarely the case. That's not to say that things can't go wrong, but the idea behind self-harm if you look at the graphic, I was happy to find this actually, because I have to say honestly, trying to find a graphic about self-harm that wasn't pictures of it was really hard. And not gonna lie, it took a lot of scrolling to find this one diagram, and I clung to it with all my might and got off that page as quickly as possible. Because yes, I have experience with this starting in middle school, from bullying and things, and that will probably be a separate video at some point. Not going to dig into it here, but the important takeaway for this is this cycle of why this is done. Really, I've always thought about it. There's two reasons that people primarily self-harm. They're kind of opposites, in a sense. Say a person is so depressed that they feel numb. Right? You hear about this with people who are really depressed. They don't really feel many emotions at all. Not just the lack of pleasure in things they used to enjoy. That's called anhedonia. That is a criteria, sure. This is even more than that. They don't feel much of emotions about anything. Good, bad, indifferent. Nothing really phases them anymore. That's how depressed they are. So the idea behind someone who might self-harm with that kind of emotional reaction, or lack thereof, you could say, would be that they're self-harming in order to feel something. It's a way to kind of open up the numb feeling, in a sense. I suppose at some point that was initially why I started, but in more recent times, in the last few years, when unfortunately it started back up, after many years of being clean from it, it really became the opposite reason. It basically more like this shows emotional overload. It doesn't show emotional dampening or numbness. It's an over-emotional reaction. And the thing about self-harm that nobody seems to get is why it becomes a pattern, why it becomes quote-unquote addicting. It's not just because the behavior itself is stimulating or because it is fun. God forbid somebody thinks it's fun. It's because it releases endorphins into your brain that allow you to feel some sort of temporary relief or pleasure or just kind of a rush of other feelings. The way I've always described it is you're taking intense psychological and emotional pain and you're turning it into physical pain. You can withstand a lot more physical pain than you can emotional and mental pain. That's just how it works. So the idea of releasing some of that as physical pain allows you to process some of it. It allows you to get some of it out. And again, because your brain releases these endorphins, you do feel temporarily that this has helped you. The problem is you realize what you've done, you feel guilt and shame about it, you hide it, and then the next thing you know, you're back at it again, looking for that fix again. So, those are the two reasons I've remember thinking a lot about. That's the two I've come to the conclusion of why this is becomes such a issue, recurring issue. So yes, the other idea again about this being for attention. I know I mentioned a story in the last video on BPD where I had the video link for Dr. Blaze Aguilera in the description. Definitely check that video out if you haven't, because it's very, very insightful. And the example he used about this idea that self-harm might not be as attention-seeking as one would think. The mom and daughter walk into the ER. The daughter had self-harmed and whatnot. Said, how long have you been doing this? Said, for 2 years. The mom was convinced, oh, it's just for attention. Well, the mom had just found out a month before, she said. He said, well, that's the worst case of attention seeking I've ever seen. The fact that it took you 2 years to find out clearly shows that is not that's rarely the case. So it is very important to remember that. And also to remember why people engage in this in the first place. So that's enough about that topic. Number 7 is going to be on the topic of depression and anxiety. And something I heard all too often. Alright, so the next topic here, number 7, is going to be this idea that people with depression and anxiety, why don't they just snap out of it? My overly simplified answer, and I think anyone with half a working brain and a small amount of logic, even someone who hasn't experienced such things, could easily challenge that with the idea of, well, don't you think if they could snap out of it or get a grip, they would? You don't honestly mean to tell me that people would intentionally just stay depressed and anxious and fearful and all of these things willingly if they could simply say, no more, and that was it? Nobody ever has an answer for that. And it's shocking that that's such simple reversal of logic so rarely ever gets actually thought of. So that's very confusing to me, for sure. I don't get that at all. So very simply, no, people cannot just snap out of a serious, severe mental illness. And the people who say, well, I did, I lost my pet, or I was stressed out about a test at school, but I pushed through it, I got better. Good for you. But every person processes and experiences things differently, and it is quite absurd to try to hold somebody else to the same level that you hold for yourself, or that someone else has held for you, expecting you to get through something tough. If you can handle things like that, great. But me, I'm not going to handle it so well. And being expected by someone who doesn't understand the concept of how I would experience something and why I would react a certain way, that's not going to happen. So no, people are not going to snap out of it just because you want them to. Sad but true. Okay, topic number 8. It kind of goes similar with this, but a step further. So this topic is going to be this construct that has been in a lot of articles and things recently about high-functioning depression or high-functioning anxiety. Hell, I've even heard high-functioning autism. To me, I think I could make a better case for it working for something like that. But in terms of depression or anxiety or paranoia, anything like that, mental illness related, I would have to say, first of all, that's not an official construct. There is no such thing in a DSM whatsoever of a specifier, high functioning or low functioning, or what, middle functioning, medium functioning. I don't know what you would even say for that. But no, that is not an official construct whatsoever. You cannot be diagnosed as a high functioning, low functioning anything. Obviously, there are specifiers for the severity: mild, moderate, severe, or extreme. That much is true. But there's no such thing as a low functioning or high functioning depression or anxiety or anything else. So with this idea, there's this idea that if you don't look sick enough, if you don't act sick enough, You know, if you don't look depressed or act depressed, then you can't possibly be depressed. Similarly, I can never say that word. With that, you have people who obviously are very severely affected by symptoms and things. And there are a lot of people who cannot hold down a job. They cannot function very well at home or at the store, these sorts of things in everyday life. There's a lot of people like me. I have a full-time job. I've had a full-time job for 2 years, and before that I was part-time at a grocery store for 3 years. And I was in school part-time for most of those years. So, yes, I was able to do a lot of these things. The school didn't work out so well, but at least in terms of employment, yes, I've been working for over 5 years. And I'm quite proud of that. That doesn't mean that I don't have good days and bad days. I don't walk into work hating everything. I mean, sure I do. And it is entirely unrealistic and honestly very sad for someone to try to say, well, you don't look depressed, so, why are you calling out of work all the time? Or anything like that. This idea that you're you're high functioning, like I said, that's not a thing. Or that you can work, so therefore you can't be have these issues. That's bullshit. Again, every person handles things differently, experiences things differently, and it's impossible to predict that at all. So that is all I will say about that. That's a very annoying thing to be told as well. Oh, you don't look depressed. What do you want me to do? Put on all black and eyeliner and I mean, what, cry all the time in public? I mean, is that what you want to see? Would that validate it to you? No, of course not. So enough about that. Let's go to the next topic, and this is another one that is mind-shattering. And this would be, what if I told you that people honestly believe this? People talk about this, people post this online for the whole world to see. That people who attempt or complete suicide are weak or selfish, uncaring. Yeah, people actually say these things, and they believe these things. And they wonder why there's such a stigma on everything mental health related. First of all, okay, to ever judge somebody who is in that position or was in that position, that's something that you simply cannot do. You cannot put yourself in a position like that when you've never been there. I've been there. Okay? And I'm not going to go into a song and dance about it right now, but suffice it to say, last June, the day before Father's Day, shit got really, really bad for me. And I was on a bunch of medication that was not working with my body at all. Multiple panic attacks every day for over 5 months. Okay? And something inside me snapped. I tried to do something bad. I caught myself. I called my friend or texted my friend. He took me to the ER. I was inpatient for 8 days at a clinic. And yes, I was there. Okay? And that will, I'm sure, be a video topic for another day. But suffice it to say, I've been there. And this idea that people are weak, people who come out of that and recover from that experience, or multiple experiences even, they're some of the strongest motherfuckers around. Okay? And I would refuse to ever hear somebody try to say that I am weak or selfish I mean, no. I'd punch anybody in the face for saying that. Whether it's to me or just to anybody that's been in that position. Okay? When you already have statistics like BPD, right? About 10% of all diagnosed people with BPD alone end up completing suicide. Bipolar is another, I think, 4% or whatever. Staggering statistics. And yet there's people who will say things like this and wonder why that number probably continues to rise. The amount of strength it takes, the amount of support it takes from friends and family and yourself, pulling yourself out of that seemingly impossible mess. There's not an ounce of weakness in doing that. And I will be damned if I hear otherwise from anyone. So, that's number 9, right? And the final topic I want to go is back to a overall general one on mental illness in its entirety. And that would be that mental illness can be cured. Short answer is no. There is no magic cure for any mental illness. There are a ton of treatment modalities and therapy options and medication options. But there is no cure. There is no magic pill that can change your personality disorder. I've said that before in the last video. There's nothing like that. There are very effective therapy treatments like DBT, dialectical behavioral therapy, that is very well studied and versed for BPD recovery. It's there. Research is there. But again, this is not a curable condition. The prognosis is this is a lifelong mental illness. And yes, you can treat symptoms, and especially things like depression and anxiety, more so than a personality disorder or even bipolar disorder. It's always thought of as being managed, being treated, but it is not being cured. There is always a chance of remission, which you could have years of no symptoms or minimal symptoms. But the real possibility of relapse is still there. That's with depression, that's with mania, that's with self-harm urges. All of it. It never really goes away. But the idea of being able to try to live your best life and work through things is very important. And that is why we're in therapy. That's why we are taking meds every day that might even have horrible side effects and make you do and feel very crazy. But having good friends, a great support system, people that believe in you and care about you and give a damn about you and tell you that and show you that, even if it's not direct, if it's in their own special way, believe me, it gets noticed, it's appreciated. My friends know who they are, and they know I do anything for them. And they're phenomenal. Every one of them. So, again, mental illness cannot directly be cured, but we're hoping every day for more and more improvement in treatment and to be the best we can be. Alright, so that was my video on 10 major misconceptions about mental illness. I hope you guys really enjoyed the video. I know it's a little bit longer, but actually this is the second time I filmed the entire video front to back because the last one was about an hour. So I just shaved off 20 minutes, so I'm very proud of myself. So if you guys like this video, please give it a thumbs up. If you have any comments or ideas for other videos you want to see me do, put them down in the comments below, and I will see you in the next video. Hope you enjoy this one, and remember, these are very serious conditions, and simply understanding and kind of changing a mindset about how you think about some of these conditions and how they affect people can really change things for the better for someone you know with these conditions. I'll see you in the next video. Have a good one. Bye.